Hi, I'm Beatrice, PhD. What used to be that time of the month is now this time of the month. Welcome to our community, a curated space for everyone going through perimenopause and menopause. A place where we can find support, good laughs, great tips on products, and lots of education on health. There's beauty in aging. Whatever beautiful means to you, this time of the month will help you find it and live it.
Today, we have a very special guest. Dr. Christiaan Stevens is a radiation oncologist. He practices in Central Ontario, but why I say he's special is because he's special to me. He is also my husband. And, talking about perimenopause, menopause, midlife, there's a lot of things to unpack, medical knowledge, but there's relationship stuff too. And I thought, what a better way to discuss both angles than with my own partner in life. So welcome, Dr. Stevens, and I'll call you Christiaan for the rest of the episode.
Thank you, Beatrice.
So menopause is having a moment, and I'm so pleased to see that because you know how much I struggled as I was discovering my entry into the perimenopause phase. And one of my struggles was not being able to express to you properly what I was going through. So when I started experiencing symptoms, what did you tell me?
I remember the moment. It was a morning, it was a weekend morning, and you were saying I'm experiencing this and that, and particularly hot flashes, having difficulty sleeping at night. And I probably quite clinically, or maybe more flippantly, kind of said, well, you're probably experiencing symptoms of menopause. And it was this kind of almost a matter-of-fact statement that I made to you.
Matter of fact. And as I was explaining additional symptoms, including, hey, I'm not changing anything about my diet, and I'm a fairly healthy eater, and I exercise. We can always do more, but I was really concerned because I felt that I wasn't myself. That was the key for me, is I didn't feel like myself. And back to that clinical flippant comment, what, you want to share with the audience a bit of that?
Yeah, I think, look at my personality. I approach things from a fact-based and evidence-based perspective. And I started drilling right down into, okay, well, these are things that you may need to do differently or change. Like, maybe have to exercise differently or eat differently. As opposed to necessarily always seeing the holistic element of things, like how it's affecting you and what this meant to you in your life. Not just physically, but also emotionally and psychologically.
I actually, let's just be real, I got really pissed off.
Yes.
Because when I said those things, you're like, you just have to exercise more, maybe eat differently. It felt like it was my fault. That's what it felt like to me. And I'm curious to know if that's how it feels like for a lot of women, because there's this sense that it's somehow everything, it's me. I can control it all. But really, the underlying biological phenomenon that was out of my control was that my estrogen levels were declining, right? And I wasn't happy with it, just exercise more. Because it felt like I'm failing somehow. And in that, I started researching, and I said, I think I want hormone therapy, menopause hormone therapy. And what was your response there?
Yeah. My initial response was somewhat perhaps muted by that. It's from my lens as a radiation oncologist, and a large part of my practice is treating women with breast cancer, and particularly women of your age. So, every day I go to work, I see women like you, and so my inherent reaction is to try to protect you against potentially what those risks might be. But again, you have to put things into context, and as we had further discussions, we can contextualize those risks. But my initial response is like, well, wait a second. What about the risks associated with that, particularly when it comes to breast cancer? So that was my initial response.
And do you think, I mean, at that time, this is a few years ago now, at that time, were you aware, beyond the Women's Health Initiative study that has been and will continue to be referred to, was that why? Because you still had that data in mind? Were you aware of any newer data?
Well, the Women's Health Initiative data was certainly something that was kind of well publicized. It had kind of been distilled down into practice. And so that there's definitely an awareness associated with that. So perhaps that was why it was kind of front of mind. I think when you sit back after the initial you let that information kind of soak in and you deliberate on it and you think about what all the risks are associated with perimenopause and menopause, and then balancing what those risks are, you'd come to a different perspective, and certainly I did as well over time. But my initial reaction was like, wait a second, that can increase your risk of breast cancer. And it's coming from my quite narrow lens, right, of cancer and seeing that every day.
So why don't we then, because if, that's an important lens to look at, let's talk about relative risk, understanding, you mentioned holistic. So there is perhaps some cancer risks, but looking at everything in context, I think it's very difficult for most of us to understand that concept of relative risk. You want to walk us through that a bit?
I would say
with hormone therapy and
I wouldn't just say most of us, talking about the lay person, I mean, even within the medical community, whether it's physicians, nurses, nurse practitioners, pharmacists, for example, the concept of risk is actually not always well understood, and people misinterpret what relative risk is, relative absolute risk, hazard ratios, things like this that we use and in papers or written and epidemiologists and statisticians indicate. So relative risk can sometimes augment or increase the perception of what a risk is. So as an example would be, if you had a jar full of 100 red marbles, and then you had one green marble in that jar, and you asked someone, what is the chance that you're going to pick out amongst that jar a green marble? Most people will say like 1 in 100 chance, right, that you would do that. Now let's say you had 2 green marbles in that jar, and so that was 100 marbles. You ask someone, what is the risk or chance of picking up 2 green marbles? That would be 1 in 50 chance. But the relative chance is 100% more of picking up a green marble.
That's a good analogy.
So if you say to someone, well, your relative risk is 100% more.
That's scary.
It's very frightening,
Yeah.
but you have to understand what the absolute risk is. So that's something that even when things are reported in the news, so information from a paper or something that's presented at a conference, some new research comes out, and then it's presented in the news, it's not always presented in a way that people truly understand what the actual risk might be. And that then is distilled down to primary care providers and others to be able to interpret that for their patients and when they come to see them in their appointments or if they call to inquire.
Mm-hmm. That's a great analogy. So let's go back to your reaction, wanting to protect me, and then my feelings of feeling a little bit I had to almost convince you, and you're not even my primary caregiver, let's be clear, you do not treat me at all. But I had to very much have almost like an angry reaction for you to stop and listen. So let's stay there for a second, because if I was feeling that way, and you're a clinician and you're thinking clinically, but like, what about the husband in this? What was the husband in all of this thinking? Were you prepared? Are you prepared to support your partner through perimenopause? What does that even look like?
That's a very good question. I think I was probably aware of it in a way, maybe even before you were, to a certain degree. I had, some of the things that you were discussing, mentioning to me, in the back of my mind, it had already been kind of, I think, Beatrice is probably, this is the time that you would expect perimenopause to occur, so it's probably what's happening. So I think internally I was already kind of coming to some element of, not terms with it, but at least clinically. But then emotionally and psychologically within the relationship, that's a whole other dynamic, because for years we've been together. We've dealt with a lot of change from when you're initially in the relationship, then you have married, and then you have children. There's a lot of dynamics and changes, but a lot of those things are kind of external and not internal health related issues. Whereas then perimenopause and menopause does change people. And so how does that affect and change the relationship? And how do we work through that together? That's something that we probably had to find our footing with initially.
And I mean, would it be fair to say that, you recognize signs because of your clinical training, perhaps, but most people don't. So imagine a partner who doesn't have that precursor knowledge. How would they feel? Do they feel like the woman going through it a bit blindsided?
I would imagine someone would be. And maybe even blindsided by what is the impact to them. Not to think selfishly, but obviously we do. Like, how does that impact me? As, you hope that you're thinking about how it impacts the person I care for and love, but there's an inherent, well, then it also impacts me to a certain degree as well. How is that going to be? And if you don't understand or are uncertain about what those changes are, then it can be perhaps a bit unsettling, I would imagine.
And I think, I don't know why this is the case, but these are really difficult things to talk about. We choose a life partner, we build a life, we build families or projects together. But talking about these types of intimate issues is kind of scary. Why do you think that is? I have ideas from a female perspective, but why do you think that is?
I think change inherently is scary because you don't know where it's leading to. And you've lived a certain way and have had a certain life and certain expectations, whether it's emotionally or sexually, for example. And then that begins to change. How is that going to change our intimacy? How is that going to change our relationship? And then when you're busy and you got lots of other things going on, like, how does that fit in with all those other things that are happening, and with our children, and then with our own work lives? It's just, you think, that's another dynamic that we have to manage together. Yeah.
One of, I hope, my value propositions for the TTOM community, this time of the month community, is I'm not afraid to ask some of the questions or make comments that I know other people are thinking or who they tell me. And it's not uncommon throughout this whole journey in creating this podcast. I've spoken to quite a few people who menstruate and going through perimenopause and menopause. And when we talk about the hot flashes, the insomnia, the anxiety, the weight gain, and it's more open. But as soon as we get down into the realm of sexuality, I even get a physical sort of leaning in from, the girlfriend network, of that feeling of, well, I love him or them or her, the partner who's not going through perimenopause. I love them, but I have decreased libido. I love them, but I'm afraid to tell them that. And so how do you have ideas on how we can create those safe spaces where we say, look, this is what's happening, and it's not, we don't like it. We don't like it, but what can we do?
I think, like everything, that's just kind of having a culture of inquiry, asking questions, open communication with one another. It certainly, when you say a decreased libido, sometimes you might internalize it as a part and saying, oh, maybe I'm less attractive to the individual, to your partner, to your loved one, right? So is there something about me that has changed? So you do kind of internalize that a little bit. Is something wrong with me? What did I do? What did I say? How am I? Could I be better? Or can do something differently? I think you have an element of insecurity yourself about that. I certainly have felt that at times over the last several years.
I was watching a really cool documentary on Netflix, and it was talking about the words we use to try and express to our partners what is happening to us. And something that was really eye-opening to me is we're a very goal-oriented society.
Yeah.
And so is intimacy sometimes. And I think that for women going through these changes where sometimes our libido is decreasing, we fear entering into an intimate moment because we fear it'll lead, there's a goal. And so then we remove ourselves from that opportunity to have the intimacy. And so, in other words, can't we just touch without the goal, the end goal? And then, so it creates a space when that's not what the partner or the person involved really wants. So words, I think this documentary really helped me understand that sometimes we just have to be able to say things like, can we have non-goal oriented touching, which sounds very academic, but what's your response to that?
I think it's quite true. If you, perhaps, I don't know whether from my perspective, but when you think, okay, my libido's up, I'm interested, and when you're going down that path and all of a sudden it's not going to lead to a final outcome, you might feel thwarted, if you wish. But if you can create those moments and you build them over a period of days or weeks, depending on the certain durations of time, then the likelihood for your partners that they'll be kind of more receptive, happier, and they're both fulfilled, irrespective of what that outcome might be.
I think on one of our shows, hopefully we'll have some expertise, sexual health and wellness, coaches or professionals that'll come on and we'll dive deeper into that. And I just want to now take a step back and take a little break from this really kind of intimate and heavy talk and really go back to this idea of making people aware that we don't necessarily control some of these, seizures. I have a funny story. Do you remember that time that I was making a capon? And for those of you who don't know what a capon is, it's a larger bird. It's kind of, I guess it's the male chicken. So it's not as big as a turkey. It's not a tiny chicken. Anyways, this beautiful meal. And I was going about it. I've done this hundreds of times. I put it in the oven and let it do its thing. And when it was time to take it out, because it should be at the right temperature and everything, I and you realized I had put it upside down. So when we talk about things like brain fog, that's a silly example. But in that moment, you were very kind of upset.
Yeah, I couldn't. It seems like such a simple thing that, how could you flip it upside down?
Yeah. How can you not pay attention? And then I feel really bad because I have done this any meal for dozens of times. But that's an example of brain fog and requiring patience and kindness and not. And I think that's where we feel that additive sense of failure.
Yeah.
Because we're not, it's that brain fog, I can't describe it. I cannot describe it. And it's these little silly things.
Yeah, I think for the partner, it's an issue of stopping and taking a breath, because you can't break these things down into defined periods of time. Oh, you're perimenopause. Okay, it's going to stop. Menopause. Okay, all that's going to be over. Done. We'll move on. It's this ongoing evolution and change. And sometimes, perhaps, I don't know whether I'm the only one who thinks this way, but you think in day-type compartments. So you think, okay, deal with our problem, you have a solution to a problem, and then you move on. So solutions focused. Whereas this is not a situation where you can take that approach. You know, there's going to be ups and downs. It's going to ebb and flow, and you just have to take a breath. Be kind, not just to your partner, but also to yourself, and realize, you know, we're in this together, and how can I help? And what is needed of me from you to help you? I think those are the questions that you were talking about earlier, but you know, what can a partner do, or what kind of discussions or safe spaces that you need? It's really asking that question. How can I help you? Mm-hmm. And it may not always be what you perceive that help to be. So
yeah, like
that's an
I don't want to
question.
think about cooking for the next week. Oh, if he takes the garbage out, now that's a little bit of the mojo getter, right? I mean, that's what men and women don't sometimes, in this particular case, I'm referring to heterosexual relationship, but sometimes it's not what you think, you know, that the help that we need. So I just made light of you, you know, being a little bit unreasonable in how, you know, I cooked something or forgot about something. But sometimes it's the person going through menopause that's harder on herself than anyone else around her. For instance, this accepting of not feeling like my old self and being hard on myself as I look at my body changing. And I'd like to be really enlightened. That's part of this journey, is to learn to see the power in aging. But it is not always easy. On the positive side, sometimes, do you feel that way? Like when I'm so critical about what I'm seeing change, how do you see me versus how I see me?
Yeah. I mean, you're as beautiful to me, if not more beautiful to me than you were when we first met. And part of that is our lifetime that we spent together. You know, the things that we've shared, the children that we have together, the life that we've made together. Those are parts of you and that make up all the components and things that are you. Those become more important as time goes on, rather than sort of necessarily the physical beauty. And so when you are hard on yourself that way, I don't see it. You know, I don't see that. Sure, you're getting older. We both are. And I can see that in myself, right? I see, oh yeah, that's changing. But it's the whole person that becomes more apparent and more evident, and that's what you love. And the person you love is not just the outside. So
I feel like we need to hear that more and say that to each other more. I think women, but everybody needs to hear that more. And it's true. And thank you for saying that. I'm glad you said that. Just don't forget to say that more often. Okay, we're going to go back to the risk thing because we didn't finish it. You gave a great analogy with the marbles. Let's draw it back to why you were concerned about me embarking on hormone therapy.
Yeah, I mean, there is a risk associated with the hormone therapy, particularly with the progesterone and estrogen combination. And the data definitely shows there's an increased risk of breast cancer associated with that. Now, you know, that risk is not particularly large. And when you think it's a little bit under 1 in 1,000 per year of using that hormone replacement therapy. So over about a 5-year period of time, that's about an additional 3 women in 1,000 that would develop breast cancer as a consequence of that. So, you know, that was kind of my calculation that I'm making in my mind. But when I stepped back and kind of looked at it from a sort of wider perspective, we got to realize that there are other modifiable risks that we all have that are as equally a risk as hormone replacement therapy might be.
Equally or even perhaps
or
more.
even greater. For example, you know, just drinking 1 glass of wine, like a standard glass of wine, which is 5 ounces of wine per day, increases your risk the equivalent of hormone replacement therapy. And if you drink 2 glasses of wine per day, that actually increases your risk beyond hormone therapy itself. Unfortunately, for example, weight gain, for example, we know contributes to that. These are all kind of modifiable. You can debate what is modifiable and what's not modifiable, but those are certainly modifiable risk factors. So when you're assessing when you're looking at all the other benefits of replacement therapy, then you've got to put it into that context. Maybe there's issues, cardiovascular disease and other things that for that particular person is maybe more important. So when you initially kind of raised that with me, I was looking at all your risk factors or modifiable risk factors, and you're already somebody who doesn't really, you don't drink very often. You are fairly active. So those of the modifiable risk factors, hormone replacement therapy is one thing that you're adding risk to. And so that's kind of where part of my kind of assessment came from.
I find it interesting that you just gave the example of hormone therapy and alcohol consumption. And yet alcohol consumption is much more accepted, practiced, almost sometimes celebrated. And in women and midlife, I find there's almost this, what's the word I'm looking for? Acceptability, as it's the girlfriend wine time. So we accept, is it because people don't realize the risk associated to it, or because people are just willing to accept the slight increase in?
I think that may be the case. However, I think the risks associated with alcohol in certain cancers is actually not well understood, at least by the general public, even within the medical community. It's not something we talk about very often. And there is actually a movement afoot to make that information more available so people are aware and they can make informed decisions. Because it's also about making an informed decision. And if that information isn't available to you or not in an easily digestible fashion, then are you truly making an informed decision? I think the question around alcohol is a much deeper societal issue that I don't have a lot of time to get into. We won't get into
that, yeah.
But I think it plays a role in that, particularly as a physician, for example, discussing my patients' alcohol intake is often not a very easy discussion to have. It can take time, and sometimes in a limited time environment, you don't have time to delve into that. There's also a defensiveness that emerges in those discussions from part of my patients. And there's a sense of judgment sometimes too. These are difficult conversations to have, but people need to be aware that it is a modifiable risk that is as significant a risk as many other things. And then an assessment of the risk for that person has to be taken into account.
Yeah, so that's the key, is assess the risk for that person, take it into context.
Right.
And weigh out the benefits as well of whatever you're assessing, benefits versus risk for that person.
For that person. These studies look at a population of people. So it's studied and these studies have what we call inclusion and exclusion criteria. And so that the data that comes out of that is applicable to the population, but for the individual person, it may not be exactly what it was for the population. So you need to look at it in the context of your family history, your own personal history, what are other risk factors that you have, and then make a decision based on that. And that requires often a conversation with your primary care provider to make a decision what's best for you. It's because it's always weighing risk and benefit. There's very rarely a situation where it's black and white. There's always gray.
Yeah. Okay, let's switch gears a little bit because I'm curious. How much did you learn about menopause in medical school?
Well, medical school was...
and residency.
20-something years ago now. So my memory's a little bit foggy in that one, but probably very little. Okay. I can imagine and recall it may have been integrated into a very short segment of learning about women's health, for example, which in and of itself was a very small component of what we learned. Most of the learning that I've done over time has been in the context of, breast cancer because of what I do. But outside of that, it's not something that I've had an opportunity, or in some respects, really the need to know more about until one another, right?
Mm-hmm.
And that's when I started to learn through you, actually, a lot more about menopause. And it actually engendered an interest in me of going back and thinking about how I'm caring for my patients who are in the perimenopausal or in age range, and the impact of the therapies that we give to women with breast cancer and how that impacts them and their, for example, chemotherapy can cause a menopause. So it's been an opportunity for me to learn. And I think that's one of the things I love about what I do, is that there's this continuous opportunity to learn and to grow.
Mm-hmm. So what advice would you give? Because you mentioned something about, your patient interactions, they are limited. They're time limited. You're seeing, sadly, many patients per day who have cancer. The life of a clinician who has a clinical practice is limited by, the hours in the day. What advice do you give to patients then to advocate for themselves? Because with a primary caregiver, it might be a little bit less intimidating, perhaps because you have a long-term relationship with your primary caregiver, the issues are more general maybe. But I find that with the hierarchy of specialization of a clinician, then the confidence of the patient might decrease to question, advocate. So what advice do you have?
My advice would be, come as prepared as you can. In terms of understanding, first of all, the system in which we function, that there is going to be a limited amount of time to have a discussion. So come with a list of questions and priorities that are important to you. Because in that interaction between clinician and patient, each has their own agenda. And you need to find that common ground in that agenda. How do you do that as soon as possible? Because that will lead to a more productive interaction. So come prepared with questions, but also some more discreet, kind of close-ended questions, but also some open-ended questions. And hopefully, the clinician also comes with an open mind as well, and open-ended questions for you to give you the opportunity to ask things that you weren't necessarily addressed in the initial part of that interaction.
That's good advice. Is there anything that I haven't mentioned that you'd like to sort of bring about in this episode? If there was something you'd want people to walk away from watching this episode?
I think it's just so important, to take off my own clinician hat in the moment, and to have just been in this moment your partner and your supporter. And so just take a step back. If you're whoever your partner might be, just to step back, take a deep breath, and say, okay, what is that individual experiencing? What might they be going through? How can I help them? And to create the opportunity to have those discussions. I think historically, menopause has been kind of shunted aside, and it's a problem open quotes, for women, and as men, we're going to just keep on moving forward.
Or she's crazy,
Yes.
or don't talk to her right now.
Yeah, which
Sorry,
is,
I'm laughing because the cat's on camera now.
Okay.
Yeah, okay.
I think we need to avoid saying those things, because it does diminish what might be, that individual, that woman might be experiencing. I lived through, we had talked about this before.
Let's talk about that. Your parents.
So when my mother went through, in retrospect, I can see this in retrospect, went through menopause, it was a very challenging time. And I think my mother really did suffer. I didn't recognize it necessarily for what it was at the time.
Well, you were a teenager.
But still, just being empathic, realizing, there must be something that's changed, but I didn't understand what that was at the time.
That's interesting. Let's talk about children then. Whose job is it? We have schools, we have families. Every family has what they want to educate their children about. Well, we focus a lot on sort of biology, anatomy, birds and bees, but not much beyond that. Would you agree?
I mean, with how we talk with our children?
Yeah, about women's reproductive systems. Yeah. All the way from getting your first period, but what happens beyond? And I know that in our home, we really try to be open about it. Not try, we are. We have been from day one. But menopause is part of that journey too, understanding that there's a whole life cycle to what a woman goes through. And if we can educate our children and make those words and biological phenomena normal, then maybe we'll move away from the she's crazy narrative or, oh, that's just menopause. Because it's hurtful.
Yeah, it really depends on the family dynamics. That's how our family has kind of chosen to discuss the things. That we're fortunate because we both come from sort of science backgrounds. So it's almost inherent in us and how we discuss things to talk about things like this. Not all families come from those backgrounds or have the comfort levels of discussing that. So what environments, what avenues are there to have those discussions? I think that has to happen on a broader societal level. So like your podcast is an opportunity. Are kids going to have access to watch this? Maybe they will be. Maybe you can direct them to that. Whose responsibility is it? I think it's a collective responsibility to address a lot of these issues that have been dismissed, ignored. There's so many of them in society, but this is one of them. And hopefully, our daughter, with that conversation, can anticipate and understand what her future may be and how to address it and how to advocate for herself and learn through you to do that more effectively. But hopefully by then, we'll be in a different place from a societal perspective to accept it. Also from our son's perspective too, that he develops an understanding of what that process is. So hopefully in the future, when he's in a relationship, whatever that relationship might be, or he has any friends or women who are going through that he can be their advocate or a supporter or an ally, if you wish. Maybe that's what we can do in our small microcosm of this universe.
Let's hope that the future for women's health is brighter, more normalized, and less invisible.
Well, it's astounding. It's astounding because half our population, right? It's astounding that it's not more visible.
Okay, we're going to lighten things up towards the end of our podcast. We do like to ask some questions. We've chosen the famous or well-known, I don't know if it's famous, Proust questionnaire. Have you heard about it?
No.
Okay, they're just fun little questions. So, what's your idea of perfect happiness?
Perfect happiness. I don't think there's such thing as perfection. It's a challenging one. I think peace. I equate happiness with peace. So things that bring me, you, our family, peace brings me happiness.
That's nice. What is your greatest fear?
Pain. not just like physical pain, but emotional pain. And I mean that in almost an existential way. We experience pain in some way all the time, but one that is not remediable.
Mm.
Yeah.
Who do you identify with as a historical figure or admire?
As a physician, it would be Osler. He's a Canadian physician, but who espoused many of the values that I hold dearly to in medicine.
William Osler.
Thinking of a person as a person and not just their disease. So Osler certainly is someone that within medicine I would is a kind of a hero, if you wish.
So Christiaan, what would be 3 takeaways for you based on today's conversation to help partners support the person going through perimenopause and menopause in their lives?
I think the first thing is to listen. And listen with an open mind. Often we listen to arrive at some conclusion or solution. I think this listening, hearing, providing a sounding board for your partner. I think that's one. And then, as built into that answer, not try to find solutions necessarily, because you probably don't have the solutions. So just being a supportive listener. Not rushing to any sort of judgment, and also to understand that as a partner, you're not going to, as a male partner, you're not going to experience this. So you're not necessarily going to understand exactly what your partner's experiencing, but certainly you can try to empathize and read and learn about it, so that you can be that supportive partner.
Well, that's a good second one. Yeah. Third one?
Have some fun. Like, it may sound strange to say, but this may change elements of your relationship. Okay, see it as an opportunity to rediscover the things about each other. And because certainly as a man, things are going to change about you sexually and physically as well. It just doesn't necessarily happen as defined a way as it may in a woman, but things will happen for you as well. So recognize that.
Have fun and rediscover.
Have fun and rediscover it, and you'll learn something about it and probably find greater fulfillment with one another over that. If you can do that.
That's really good. All right, then the last question that we ask everyone is, Christiaan, what makes you feel beautiful? And the key word is feel.
Well, because tomorrow's Valentine's Day, can I say you?
Aw. Thank
but
you.
If you think that's too trite.
Yeah, what makes you feel beautiful?
I never really thought of it in that way. But when I'm active and I'm doing something kind of physical, whether it's sports-wise or athletically, that actually makes me feel good. And if you want to equate good to beautiful in that way, that's what makes me feel beautiful.
Well, I really want to thank you for putting yourself out there, sitting on this couch with me and touching on subjects that most people, it's a little bit uncomfortable to talk about, but we did it with kindness, I think. And so thank you for coming.
Sometimes I'm going to bring you glamour, and sometimes I'm going to bring you medical grade heel balm. We all know that through perimenopause and menopause, we just get drier everywhere. Our feet are no exception. Use a product that really, really works.
I recommend Flexitol. Flexitol can be found in most pharmacies and it contains urea at a high concentration. Yes, I said urea, the thing you find naturally in your pee and in your skin. And urea does two things really, really well. It gets rid of that dead layer of skin, but it also retains moisture in and of itself. So that's why it works. No word of a lie, after one use, you will see a difference. We touch our feet all the time. Wouldn't it be nice if someone touched our feet and didn't cringe or scream? If you use this product, you will see a dramatic difference and you might actually invite the kind of screaming you really want.
The content expressed in this time of the month is not intended to be a substitute for medical advice. The views and opinions expressed on this show are those of the speakers.